Good morning, everyone. Healthcare is a very unique sector. It deals with human vulnerabilities. It has outcomes that truly matter and a lot of deep trust. But at the same time, it operates in a segment that requires a lot of investment, scale, long-term sustainability. Now, the panel today is titled Ethical Care versus Profitable Care. And is that really a conflict? And where do we draw the line? But a more useful question would be that does this conflict really exist? And if it exists, is this some sort of a tension that needs to be continuously managed? Now, profitability in healthcare usually leads to a lot of questions and sometimes suspicion as well. But while that happens, without financial sustainability, we will not be able to have large-scale investment and scale, not a lot of quality infrastructure within healthcare institutions. But at the same time, without having very high level of ethical standards, no healthcare institution, however profitable, would be able to gather that long-term trust, would not be able to get that legitimacy. Now, today's discussion would not be about absolutes. It will be about real-world leadership. It will be about decisions that healthcare leaders face every day and how do these shape the overall trust and sustainability within the system. Now, today, our healthcare leaders come at an intersection of finance, operations, care delivery. And while they are here, I would like to facilitate a conversation, a thoughtful one that reflects on the true realities of running healthcare institutions with both patients and purpose firmly at its center. So let me start with a very simple question. In your daily role, how do you personally define ethical care? We can go in this order, Mr. Sreejith, Mr. Rajiv, and Mr. Dilip.
Good morning, everybody. Thanks a lot for this opportunity to discuss about a very interesting topic. Right? So, in my daily role, the way we define ethical healthcare is as follows. Right? It is a clearly process, protocols-driven care, which has 3 or 4 critical elements which cannot be compromised. The first one is we need to empower the clinician to take a decision in the best interest of the patient and looking at the long-term interest, not the short-term gain, but the long-term interest of the patient, which means that the protocols, whatever we do with respect to diagnostics, plan of care, etc., has to be evidence-based and what is relevant for that particular patient's health condition. That's the first marker it has to click. Second one is that once that is done, there is a huge amount of informed plan of care that comes into. Whatever the clinician is deciding, it has to be transparently communicated. The pathways of care, the possible duration it may take, the cost that is involved, and what is the kind of outcomes. That comes super critical. A lot of time, the line of ethics also, because a lot of patients are not able to envisage the outcomes that the care can deliver. Like doctor said, right? I mean, clinical outcomes driven care becomes more critical for NCDs, where some of these kind of things get blurred. And once that is also done in terms of the provision of care, right, that outcomes needs to be tracked, and at any point of time that informed plan of care has to continue. And this cannot be done at an individual center or a doctor or a clinician level. It has to be institutionalized. Therefore, on top of it, there has to be a strong governance, which takes and looks at these cases on a day-to-day basis and see if everybody is adhering to this, right? So when you have such kind of a protocols-based process, the profitability or the profit that is being made is ethically acceptable, right? I mean, that's the whole crux of it. The profitability is an outcome of this kind of an ethics-driven care. That's the way I would define from my operations experience the context, the point of profit. Thanks.
Mr. Rajiv.
Good morning, everyone. I'm Rajiv Sharma. Since I'm the CFO, so just to be short and quick, ethical care for us from the finance side is that basically when you do the pricing of the services, you have to be very reasonable, because it's not only about making profits and it's not only about looking into what your competitors are earning. So making that pricing reasonable and affordable, that is the one ethical thing which we do. Then second thing is the transparent billing. That transparency in the billing and the services, and our billing team, they have to discuss it every day or every step, explain if the charges are increasing or going down. So based on these transparencies, Then obviously the informed consent, when the planned line of treatment changes, the treatment costs go beyond the estimates given to the patients. So that has to be properly well communicated, not even through the doctors, but from the finance side, from the billing side. So this is the basically the ethical things which come in my role. Definitely other clinical leaders will speak their ethical part, so being precise to that. But if you say there is a conflict, because since CFOs are meant to get the profits, but actually the conflict is not between that profit and that ethical. The conflict is actually into the decisions which we have to take, because at one end we need money to have that best infrastructure, best equipments, retain the best resources, and then providing the ethical and the affordable care. So these decisions are the actual conflicts. That's what I can say. Thank you.
Mr. Dilip.
Yeah, thank you. Good morning to all, and thanks for the setup. So from an ethical care perspective and ethics perspective, if we want to define ethics, the way I would look at it and we would look at it is that we need to be able to demonstrate that we are doing the right thing. And that right thing can be in various aspects. It can be in the kind of line of treatment, it can be the kind of approach we follow versus the patient, what is the communication we give to the patient, be it on the course of action, be it on the billing estimates. Typically, you find that most suspicion arises on the cost of treatment. And that is something we need to allay. And the only way it can be allayed is by offering various kinds of options available and the cost of each option, and then decide based on protocols the best course of action. Now, if you do that, as Rajiv also hinted upon it, if you're doing the right thing, the quality will follow, and at the end of it, profitability will follow and sustainability will follow. So in order to demonstrate ethical behavior, you've got to be seen to be doing the right thing with empathy. That's the way we would look at it.
That's great. Mr. Rajiv, you talked about profits and using that profits for quality. Mr. Dilip, you mentioned about doing a lot in terms of demonstration because other things will follow suit. But why does this suspicion even arise? I would request Mr. Rajiv to highlight something from his perspective when looking at Amrita Institutes of Medical Sciences, that why do payers, why do patients have that sense of suspicion? What would arise to this particular context?
See, healthcare, as you know, we are dealing with humans, and any revenue which is generated from saving lives is always under the scanner of suspicion, and especially when the planned line of treatment, the things go beyond that, because anything which goes beyond the planned line of treatment definitely escalates the bill and the cost. So that results in the suspicion. I can just give you a recent example from our hospital. On 24th January, that was I think Saturday, so there was an orthopedic surgery for a patient, an estimate was given. But what happened, that surgery went beyond night, and when the doctor was doing the operation, on that table, he found another thing had to be done on that patient for the betterment of that patient, for that treatment. So he obviously took the consent of the attendant who was present at that time, did that procedure, everything. The next 2 days were holidays, Sunday and 26th January. On 27th, the bill shot up. So the actual next of kin of that patient came to the billing, and when he asked what is the treatment, what was these services, when he saw that bill has escalated almost double, so he got furious. That is natural. So then obviously that communication with the doctors and the patient explained the need of that procedure. The billing team went into quick action, talked to the TPAs, talked to the senior levels, authorities in the TPAs, and got those things resolved. Because if something deviates from the line of treatment, that results in a suspicion. That is what has been asked. Because people think why it was necessary. even the TPAs or the payers, they ask why, they have to justify. So when we have a very transparent presentation of the justification, why it was needed, supported by the diagnostics, supported by this, so these things can be sorted out. So this is the main cause of the suspicion. And the solution is we have to be very clear on how we do it. And then quick action, because if the TPA is rejected and we just said, okay, they have rejected, you have to pay the money, the patient will always feel he has been cheated upon. So we have to be on the other side of the table as well. We have to think from the patient's view. This is what my billing team or our billing team does, or in fact, most of the hospitals do. So this is how we can support them.
Mr. Dilip?
Yeah. So I think the cause for suspicion is several. The causes can typically relate to billing, relate to tests, procedures being recommended by the clinician. Now, somewhere it's a matter of trust. Ultimately, you've got to trust your clinician. If the clinician is following the protocols and recommending certain tests and procedures, then one has to have that faith and be guided by the clinician. But today we are all doctors. We are all doctors thanks to Google and ChatGPT. So we would like to do our own research. We do our research and ask ourselves and ask our friends, relatives and doctors in the family, is this required? Why was it recommended? Should it not have been done differently? There is a lot of trust which you have to impose in your doctor for the line of treatment. There is a great deal of judgment involved. It is not an Excel spreadsheet or a program which will do zeros and ones. So where there is human judgment involved, there is always suspicion. However, the moment you start treating things transparently, communicating, clearly explaining the options available, the costs associated with it, as I first mentioned, a lot of these things do get nullified and the suspicions get dispelled. So I think these suspicions and the way that these suspicions can be dispelled is through transparency and greater communication. Over communication is a better thing to do than under communication in such situations.
Mr. Sreejith, you're now setting up Apollo Ayurveda hospitals, taking full charge. A very important question that comes to our mind when we talk about affordability, profitability, sustainability, is that can high quality healthcare be provided without compromising any kind of a profitability or sustainability goals? So how do you look at it?
I think it's possible. Short answer, yes. But I just want to take this affordability point, right? So affordability, my personal experience says that it's a relative term, right? I mean, there's nothing like an absolute affordability, right? It depends on the catch, and I'm talking about brick and mortar hospitals, which have a hyperlocal behavior also. It depends a lot on the catchment that you are in, the kind of patients you are targeting, what is their ability to pay. There are two aspects in that. What is their ability to pay, and for a given promise of quality and outcome, how much they are willing to pay, right? So that whole thing is predicated, this affordability question is predicated on the way we design the hospitals, right? The whole setup and the way we communicate what we are going to offer and the clinical excellence that we deliver at that place. I'll quote an example, right? We have 14 centers across the country. I have one center here in Nehru Enclave. Now, as you know, Nehru Enclave is a little more affluent place, and especially for chains of hospital, there are multiple base costs involved, right? So the rents, leases, etc., all those things I pay could be 70 to 80% higher than say a center that is there in Bangalore. So then what happens is that naturally my base cost is higher, consequently the cost of delivery also is going to be higher. And what does this mean? This means that probably the audience that I need to target also is slightly different. Now, if my service excellence team and my marketing team is not able to attract that kind of an audience, there is a little bit of a trust deficit that comes through. People start thinking it's too expensive, right? And then the last thing that we want to do is that compromise the quality, right? We just spoke of what is ethics in healthcare, right? So we will not do that also. So the important part there is that, we need to kind of, all these things should click together. And most important is the clinical delivery also, right? Please understand these are all capital intensive businesses, brick and mortar hospitals. And we are not going to be a fly-by-night operator where we kind of set up and then kind of get out of that place in 2-3 years. That's not the intent. We are going to be there for the next 30, 40, 50 years. So like Mr. Harbinder said, we have to be evoking that empathy clinically. We need to get the clinical outcomes that is desired, because eventually my footfalls, my whole business is predicated on people having trust, people coming back, right? The amount of people saying that, oh, this hospital gives excellent care, which is best for the patient. So unless and until you deliver what you promise, and we promise what the patients need, eventually it's not a sustainable business. So those are the places where the margins get compromised. So we make it a point to make sure the clinical delivery is of the highest quality, to answer your question. And we also look at a very careful choice of the location, target group and everything, and appropriately deliver the communication and everything around that. Thanks.
Very well thought plan that you already have, and good success might come way soon. Mr. Dilip, maybe you'd want to share some instance where margins truly got tested.
Yeah, so I think sustainability, affordability, it's a question which is a fine balance. And margins is really an outcome. Once you have your clinical outcomes, you build the trust, people come repeatedly to you, and margins follow. Margins, while it's important to ensure the sustainability of the organization for reinvesting, for having the ability to meet its costs and to reinvest in the latest of technologies, best of clinicians, and well-located infrastructure which is accessible. All of this comes at a cost. Now, how do you right-size the cost? Right-sizing of the cost has been attempted many times in the industry. But what do you charge for? Do you charge for, let's say, the room rent? Do you charge for the procedures, the medicines, consumables? What else do you charge for? Some hospitals charge for registration fees, documentation fees, TPA fees, but these are nominal and small amounts. Have you seen any hospital charging separately as a line item for housekeeping cost? Probably not. It's a cost which has to be recovered through various other costs that are being charged. Doctor fees, does that cover housekeeping? No. Does the room rent cover housekeeping? Possibly not. Now let's take a ward where there are 4 or 6 patients versus a single room. Now the single room cost may be 5-10 times higher, or deluxe room costs maybe 5-10 times higher than a ward bed. But where do you need more housekeeping? It's in the ward. Much greater footfalls. You need to keep the hygiene levels high. You need to ensure that hospital-acquired infections are limited. Quality. Outcomes. Now, is that getting compromised by not charging housekeeping fees? Probably not. You still need to offer it. But it has to be distributed across other pricing. So pricing, right sizing of costs is something which has been attempted many times by various organizations, by the government institutions, by consultants, by hospitals themselves. But really there hasn't been a standardization across this. And it's very difficult to do it. It's not easy. So at the end of it, sustainability, quality, and the quality of the care go hand in hand. It can be done, but it's not an easy task.
Talking about making difficult decisions and solving them using some sort of a structure. So when it comes to getting these ethical practices in place without individual intent, but something which the organization really follows, what are the kind of processes, frameworks, probably incentive structures, whatever has been set and experimented with? How is that you have your take on this? How is that you start implementing this across the organization? Mr. Rajiv?
Well, in the beginning I said the conflicts in this is basically the conflicts in the decisions. For example, whether we should go for a high-end cancer treating equipment, or we should go deep into, say, underserved communities and do this, or we increase the emergency beds rather than putting this cost. In our case, Amrita hospitals, actually we have to maintain both. So it becomes more challenging for us. But again, since, as you know, Amrita Hospital is a non-profit organization run by a charitable trust, Mata Amrita Nandmai Mat, under the divine grace of our Holy Amma. So we are bound by the, you can say, the missions and the visions of having the best quality healthcare, best infrastructure, latest robotics, latest AI, everything. You know, we are the largest hospital, private single unit hospital, 2,600 bedded hospital with around 530 odd ICU critical care beds and 64 operation theaters. So looking into that infrastructure, over 145 acres of land with the medical college, clinical research, nursing college, all integrated into one. At the same time, our tariffs have to be very reasonably low so that they are affordable. Our single room, the private deluxe room, is just 5,000 rupees, because this is our mission and vision. We move into the villages, we go into the community outreach, and in fact, we are the hospital, we have taken Ayushman for all the specialities, and we have treated more than 15,000 patients of Ayushman also. So looking into this, it's a very challenging thing to balance this. So for this, since we have to follow these things and we have to dedicatedly take care of the ethical care and the affordable patients, so we work on different strategies. So first is obviously the cost optimization, we can say. I will not use the word cost cutting, which generally the people think, any business, because they think they have to be competitive, they cannot raise their revenues, but what do? They cut the cost. But actually cutting costs is sometimes more costlier. So that's why we use the word cost optimization, bare minimum, which we can do through some lean management principles, looking into throughput. And the best thing to reduce the cost is reduce the idle times and the proper utilization of resources. So this is how we do that. Capacities, how they are best utilized, how the throughput is maintained, so that the volumes cover up for the costs, right? And since all the leadership is down, these ethics are cascaded down to everyone till the light thing. So we also, and see, although we are not on the incentive schemes, but since you asked the questions, so incentives should not be based on the revenues and the volumes. This is what I feel. The incentives should be based on the patient-centric outcomes and the KPIs which we should monitor, not only the profits and everything. It should be basically the reduction in the mortality rates, the class B or the central line acquired infections, how they have been reduced, how happy the patient has been. Because see, just like in any service industry, on any, even the products also, a happy customer becomes a brand loyal, you can say, and they can bring in more patients. So if you go into the outreach, give them the proper care with the quality, transparent thing, then definitely these volumes will cover up for your costs. This is how we think, and then this is all trained into the each staff. This is what we do and we plan to do.
A difficult job doing this is that how do we get the entire leadership aligned? How do we make sure that structurally these things become part of what is routine, rather than, okay, this is something which would be my own view. Now you've had significant amount of experience dealing with, again, changes. Mr. Dilip, you also talked about a lot of experimentation happening around this way. Things have worked, things have not worked as well. What is that you see needs to be embedded structurally so that we are able to get to the best outcome?
So I think this is really a question of setting in right systems and processes and procedures and empowering hospital teams at the lowest level. It's not a boardroom or a corporate decision which needs to be done, but the corporate structure has to be laid out, defined that these are the protocols which need to be measured, followed, and processes which need to be followed rigidly, well, mostly rigidly, because there is a lot of judgment which needs to be taken at the grassroots level, which should then be left, and the grassroots level teams need to be empowered to take those decisions for deviations from what has been decided. Now, in order to do that, it can be relating to what kind of course of treatment, what kind of step-by-step protocols to be followed, what kind of medication to be given. Is it the original molecule or generic molecule which can be given for a particular kind of patient? All those kind of things can be defined in the protocol, but left to the good judgment of the clinician. So there has to be that empowerment. Now, a lot of this comes through the kind of maturity that hospital team or the clinician team has in ensuring that the best kind of care and the best kind of results and outcomes are given. And as Rajiv mentioned, the measurement should not be just on financial parameters. There has to be KPIs which are measured, which are measures of quality, be it measures of mortality, hospital acquired infections, be it readmissions, be it, there are a host of parameters which are defined. If a hospital is NABH accredited, there is a whole series of clinical outcomes and parameters which have to be followed and practiced and discussed and improved upon. But when you go to an investor presentation, you will never come across discussion around any of these, right? So that's the unfortunate part of it, because ultimately the people who are funding private institutions are looking at only the financial parameters. They don't necessarily look at some of the softer issues. So that is a mindset change which needs to be brought about. Not an easy task, unlikely to happen too rapidly, because ultimately in the private sector, the investment will come from people who are looking at returns on investment. While it's considered to be a social sector, but who pays for it? It's the individual, there is insurance, and there could be a government payer. Ultimately, with the penetration of insurance, there could be some pressures which are going to be put back on institutions to do the right things. So it's a counterbalancing act which needs to be played.
Coming from the mouth of a CFO, how do we balance these numbers and how do we get investors to be onboarded on the same metrics that the hospital and the consumers would care about? But talking about the future, there's a lot of tech advancement happening, alternate medicines coming through. How do all of these balances evolve when we look at these new approaches, new age technologies, etc., coming into place? Why don't you share your thoughts, Mr. Sreejith?
Yeah, thank you. So we all now hear that technology is going to be the next game changer, and already there are well articulated points about how technology can bring in efficiency, precision diagnosis, improve the doctor's time being more valued, automatic transcriptions, ambient listening, all these things are happening. But I think for me, if I were to look at the country as a whole, right, I think the game changer is going to be, if there is a paradigm shift that is happening from a curative healthcare model to a preventive healthcare model, right? So if you look at WHO also, the way, the healthcare, the life cycle is being defined, there are multiple places where they call quote unquote windows of opportunity. There's a primal prevention where, is there anything that we can do for gestational health? Primary health is basically, avoiding latent risk identification, identifying if the patient can be prevented, for example, being diabetic itself, that pre-diabetes stage and, insulin resistant stage, etc. Secondary prevention where, the patient has an onset of this thing, but can we prevent that becoming a complex situation like a foot ulcer or a neuropathy or something like that? And tertiary prevention where, let's say, a stroke patient comes out, that window of golden period where you're able to rehabilitate and avoid the whole thing. So That kind of a shift is going to be the biggest game changer for me. And that is where technology has a big play, because a lot of predictive models based on AI, LLMs, etc. are coming more and more. And things like, especially customer lifecycle management, that interplay between a quaternary care hospital to a step-down care to a home health care, all these things have heavy investment of technology. And players like us who are in the, traditional medicine like Ayush, etc., also has proven and strong processes, procedures where some of these conditions can be, reversed. All those things are possible. So that's where a pluralistic system can come through and significantly reduce the healthcare costs in the country. And this is an important part because, in a country like India where 50% of healthcare is being delivered by a private players like us, so the ethical profitability is something which has to come through, point number one. And point number two is that with the prevalence of NCDs, right, we can always look at how many people have diabetes, CKD, all these conditions. If they miss these windows of opportunity, the healthcare cost and burden is going to be massive, right? So that's the whole play. And last point, you also asked about consumer awareness. There's also excellent solutions coming in consumer awareness, right? Like Mr. Dilip said, people look at ChatGPT for solutions today. How do we ethically communicate through this, right? I mean, one exercise you can do is that, take 4 or 5 healthcare players like us, go to Perplexity and search, benchmark all these players against ethical communication. You can see the results for yourself, right? I mean, so that's something which we, for example, take pride on. We follow all those Google EAT framework, ABCD, so that we don't get recommendatory, we don't do false claims, all those kind of things. So we tend to spend all that thing that's in ethics in communication. So technology is going to be a game changer. People like us who are in the traditional medicine is going to add tremendous value in this NCD journey, and consumer awareness is going to be a critical piece which fits into the whole puzzle. That's how I would say. Thank you.
Very well said. Very shrinking world in terms of information disparity and having a very tight control. Very quick take from you, Mr. Rajiv, in terms of what evolves for you in the next 2, 3, 5 years.
Okay. I'll just pin down into only 2 points because of the shortage of time. So first thing is technology. Even in our scholastic days, there was an essay, is technology a boon or a bane? So definitely technology is a boon if we use it as a support. AI models definitely help you in reducing a consultant's time in diagnosing and finding out how things can be quickly turned, and they can define a line of treatment. I'll just give you again a real life example from our hospital. One of my far related uncles developed rarest of rare cancers, eccrine porocarcinoma, and that is around 0.005% probability of skin cancers to develop that. Even the doctors have not heard that word, what is eccrine porocarcinoma. And so if they have not even studied that, then how do you treat it? So in this case, the AI helps you. How many cases in the world? I think he was the first known case in India, and this happened just 2-3 months back, and around few hundreds around the world. So AI helps you identifying how many such similar cases, how they were treated, what were the outcomes, and how the best treatment can be given for the benefit of the patient. So quickly he was treated, and luckily he has survived, and thanks to the technology again. So this is how. And again, if we go into that telemedicine, teleradiology, these things are actually not going to take the job of the doctor, but they are going to assist the doctors and save these times. And when you again save these idle times, which I talked earlier, reduces the cost, and that can be cascaded down to a lower pricing. And quick second point is, like Sreejith ji told, Ayurveda, holistic sciences, and the alternative therapies. The medicine in future is going to collaborate. Ayurveda, Siddha, Unani, homeopathy, allopathy, this has to be collaborated. Why? Because preventive, which he clearly said, and palliative, the other end of the treatment. So both cases, if they are supported by the alternative therapies, and definitely the emergency situation and the surgical through allopathic, and when these three or all the medical sciences club together, the total costs will get reduced. I'll again speak from the financial part, because the treatment of preventive, which will reduce the risk of a higher cost of a surgery or something, and then later on for palliative treatment is just rehabilitation or something. So when all these things are collaborated, the cost will reduce, and this is definitely going to help the patients.
Great. So once we come to the close of this discussion, one theme has emerged very clearly, that ethical care and profitable care, these are not really opposing forces. These in the long term are truly interdependent. When we're looking at ethical practices, these lead to trust, and it is this trust, whether it is with patients, payers, or even regulators, that helps organizations sustain through this growth, complexity, and change phase. What we've also heard is from the leaders that when it comes to ethical leadership, it is not really about taking those dramatically moral choices, but it is about everyday routines and structures in place. Also a very important thing, that every organization builds its own boundaries and plans depending upon the guidance from their accountability, governance structures, and culture. But one thing that resonates across as a common is ethics cannot be an afterthought, and at the same time, profitability cannot be pursued just in isolation. In fact, financial sustainability empowers the ethical care, and ethical behavior itself is helping strengthen that sustainability. Thank you so much to the panelists for sharing their perspectives so candidly, and to the audience for engaging in a conversation that truly resides at the center of healthcare leadership. Thank you, everyone.